All right, so the first question is, how are fertility and Hashimoto's connected? So Hashimoto's, I think most of you probably know, is an autoimmune condition that affects the thyroid over time. So it is studied and associated with a higher risk of fertility issues as well as preterm labor and miscarriage. The good news is those risks can be mitigated with appropriate treatment. So there are lots of different studies looking at this, and some are inconclusive. There are also some studies which show the opposite. But for the most part, what's well accepted is that women with Hashimoto's are likely to need thyroid medication. And even if you go into pregnancy with normal thyroid function, women with Hashimoto's are more likely to develop hypothyroidism. So remember, Hashimoto's is autoimmune, but it causes hypothyroidism over time. And not everybody with thyroid peroxidase or thyroid globulin antibodies is actually hypothyroid. Despite that, we should still consider treatment in anybody who has Hashimoto's, even if you're euthyroid, meaning normal thyroid function. All right, so the next question is it difficult to get pregnant having Hashimoto's? And it's a complicated answer. I think with Hashimoto's, there's two different things to consider. And the first one is thyroid function. So if you are hypothyroid, we know that that is associated with a decreased or increased rate of infertility, I should say. So it can be difficult if you are untreated or undertreated for hypothyroidism and you have Hashimoto's. The second piece is the autoimmune component, which I think is really there is this kind of inflammation autoimmune component going on with a lot of patients, which requires them to first address some underlying health issues. So I see this every day in my practice where there's underlying issues with gut stuff, maybe they think it's IBS, or maybe even environmental exposures like mold, and those can really affect fertility as well. And so if you go into trying to conceive and thyroid antibodies are sky high, that might be a sign or an opportunity to work on your underlying health first before you try to conceive. Not only because fertility will be better, but I think pregnancy, postpartum outcomes will be better as well. Okay, next up, I sort of addressed this already, but how to best prepare to have a healthy pregnancy with high TPO levels. And so I think, again, it's like a two-part issue when you've got Hashimoto's. Number one, you got to make sure your thyroid hormone and your thyroid medication is dialed in if you're on thyroid meds, and that's checked often. And so you want to make sure your TSH is less than 2.5. Get those baseline levels. I like to go to like TSH around 1. But number two is if you have high TPO levels, if you can step back for a minute, if you can work with a physician who understands how to help you decrease those levels, I think you'll have more success at the end of the day. And when I'm talking high TPO levels, I mean, I have some patients where it's like greater than 900. If you're in the 100s, it really depends. And I think it depends on how you feel. What I see is that as patients feel better and do better, and as we work on gut healing and environmental kind of issues, they feel better and their antibodies come down. And so there is a chance that your antibodies can decrease. I know that's not a popular sentiment among conventional doctors sometimes, but it is something I see clinically in my practice all the time. If you're one of my patients, chime in here because I know you've seen it too. And, if you can work with a physician who can help you bring those levels down, I think that would be awesome. Some easy ways to do it: gluten-free diet. And I also use low-dose naltrexone sometimes, but often it's a lot more complicated than that and really patient by patient. All right, so we've got a question about supplementation. Any specific vitamins I should take while pregnant with Hashis? So prenatals, obviously, but I think importantly, whether you have Hashimoto's or not, it's about finding the right prenatal, and that's not that easy. So best case is to work with a physician who can help direct you, but obviously that's not as easy as it sounds. You'll want to look at your iron levels. There are some people who don't need additional iron. Seeking Health has a good prenatal that's iron-free. Otherwise, most people need additional iron, in which case I'll use other brands. I really like the Vitamin IQ brand because it has a good amount of choline. And I also like the +1 prenatal from Metagenics because it has a lot of choline as well. Of course, you want to make sure you have methylated Bs, so methylfolate, methyl B12, that's my favorite, and that's always my vote. But methyl Bs, choline, which is a big one. Don't make the mistake of using one that has a choline of like 17 milligrams. It should be like hundreds of milligrams. Even the American Medical Association recommends 450 milligrams of choline in prenatal. So it's just not very common to be included. And then DHA supplementation, like a good fish oil. But frankly, it's not that much different for somebody with Hashimoto's than it is for somebody without. Okay, and the last question is, how does subclinical hypothyroidism affect fertility if no meds are prescribed? And there are multiple studies looking at this question. Subclinical hypothyroidism has a couple different definitions. So sometimes people will talk about it in terms of having a TSH in the upper range of what's considered normal, so above 2.5. Some people talk about subclinical hypothyroidism when TSH is actually outside of the normal range, but free T4 is low. I'm going to sort of frame it because much of the literature looks at a population where TSH is greater than 2.5. There are multiple studies which show improvement in fertility and pregnancy outcome when levothyroxine, what they call LT4 in these studies, so a T4 medication is used to treat hypothyroidism or subclinical hypothyroidism to get TSH less than 2.5. There are a couple studies which found there was no change, but really in this instance, it's like risk benefit. Like what's the risk of adding in a little bit of thyroid medication and what's the benefit? So benefits are huge. Risks are really quite low. If you're not over medicating with thyroid medication, risks of using thyroid medication when prescribed appropriately by your physician are really quite low. So risk benefit analysis is, I say, I would always err on the side of treatment with subclinical hypothyroidism anytime TSH is over 2.5. And that is actually in line with American Academy of Endocrinology guidelines, which I'll sum up next. Okay, so last one is a bonus question, but I just want to reiterate, what are the official recommendations? So in 2012, AACE, which is the American Academy of Clinical Endocrinology, issued some guidelines recommending treatment with thyroid medication called LT4 or levothyroxine for women who meet the following criteria. So anybody who is preconception or in the first trimester of pregnancy, if their TSH exceeds 2.5, in the second trimester exceeding 3, third trimester exceeding 3.5. So what that means is if you're trying to conceive and or in early pregnancy, you'll want to check your TSH and make sure it's less than 2.5. I will note in 2017, the American Thyroid Association sort of updated these guidelines. Essentially, they said, despite imperfect data, risk outweighs benefit, and we should treat anybody with overt hypothyroidism. They acknowledge that there's insufficient evidence to determine if treatment with medication improves fertility for subclinical hypothyroidism, so that's when TSH isn't super high. But they recognize that treating subclinical hypothyroidism could be considered given its ability to prevent the progression to hypothyroidism when pregnancy is achieved and the minimal risk. So again, it's all back to risk benefit. And, in my book, I say,